Hi, this video will feature a case of colorectal adenocarcinoma which appears to have metastasized to the liver. I'll be using the means of histopathology as well as immunohistochemistry to determine the origin of liver metastasis for this patient. The current image displayed is an overview of a cross-section of the patient's colon, more specifically within the rectosigmoid region. Malignant cells can be clearly seen stained a deep purple color as these neoplastic cells contain hyperchromatic nuclei which stain more intensely than normal cells. We'll start with grading. The image on the left depicts normal goblet cells within the mucosa layer. These cells are lined in a uniform and glandular structure with relatively small nuclei. The white dots within are small droplets of mucus indicating good functionality within the cell. However, the image on the right shows abnormal goblet cells which have been invaded by neoplasm. The unified glandular structure has been distorted quite heavily and the nuclei appear to be thicker and darker. This is due to the hyperchromatic enlarged nuclei which indicate cell proliferation is occurring. There are very few white dots near the highly differentiated cell which suggest impeded cell functionality as very little mucus secretions are present. This next image shows a pericolic lymph node in which most of the lymphocytes have been destroyed and replaced by neoplasm. However, the neoplastic cells appear to be well encapsulated within the original node, which imply malignancy as the only route of entry is via the lymphatic system. Again here you can see the dark purple stained hyperchromatic nuclei of the compromised hepatocytes. The neoplastic cells appear to be forming a glandular structure that is uncommon in a normal liver biopsy. This suggests these cells are foreign and indicate this is a form of liver metastasis. Necrosis has also occurred as the neoplasm has outgrown the nutrient and oxygen supply available, hence why no secondary tumor has yet materialized. This has resulted in a desmoplastic response leaving scar tissue. Now onto immunohistochemistry. The expression pattern of keratin 20 and keratin 7 will be observed using the patient's liver core biopsy to identify the origin of liver metastasis. The appendix was used as a positive control due to the fact that they are lined with simple columnar epithelium which express K20 in abundance. This can be seen as a deep brown stain on the left image. From the patient's liver biopsy, it can clearly be seen that the malignant cells have readily taken up the stain, turning brown, meaning it's positive for K20. The left image illustrates a tonsil control slide for K7, which was partially positive but mostly negative. The brown stained areas are positive for K7, with the remaining areas being negative. When looking at the liver biopsy, some small brown stains are visible. This is because K7 is expressed by the biliary cells of the liver. However, the neoplastic cells do not stain brown, which indicate the absence of K7. This implies that the patient does indeed have a type of colon cancer, as K20 positive and K7 negative patterns are primarily observed in colorectal adenocarcinomas. After putting together the histological observation of goblet cell morphology, the infiltration of the lymphatic system, and the keratin 20 positive and keratin 7 negative pattern, the origin of liver metastasis is the colon. Hence, this is a case of colorectal adenocarcinoma.